Good morning, everyone. My name is Vern Sinares, and I want to thank everyone for joining us this morning. I'm from right outside of Houston, Texas, and this morning we are going to discuss a lightning round Q&A with Dr. Chen from Cleveland Clinic. For those of you who do not know me, I am a patient advocate. I have had lymphedema myself for almost 30 years, and I've been a patient advocate for almost 8 years. 5 of those years have been full-time, and I've worked with hundreds, if not thousands, of patients across the country and from around the world with various questions and connecting them with resources that are available in the community. And just recently, I launched a YouTube channel. It's called Magenta Table Talk. And the purpose of the Table Talk is to connect patients with fellow advocates, friends in the community, and clinical experts like Dr. Chen. Dr. Chen and I did this exercise 2 years ago. It was fun. It was a great success. So before we get started, I wanted to go over a couple of housekeeping rules. Number one, even though you may know me in another role or from a past role, the opinions in this YouTube are my own. They're not representative of any organization, past or present. Dr. Chen and I have no financial relationship whatsoever. He's not being paid to interview, and I'm not being paid by him. And also, there is no medical relationship. So I have never been a patient of Dr. Chen, nor am I a candidate for surgery. So this is two friends getting together with the objective and the mission to help patients and to further patient education. And one of the reasons why this idea also came to the forefront, as I was seeing a lot of chatter across social media. And so I thought, well, now is a great opportunity to revisit the Q&A. So without further ado, Dr. Chen, feel free to introduce yourself.
Well, thank you. I want to thank Vern for providing this opportunity. So one thing that I always felt that I could have done a better job, although not allowing to do so, when I see patients in my clinic, is they always came with so many questions, and I never had enough time to answer all of their questions, even though I always try to stay with them until all of their questions are answered. And as a result, my clinic usually finish at night, and I'm usually for patients that are scheduled later in the day and the afternoon, invariably they had to wait a long time because we always ran overtime assigned for each of the patient, and still their questions are not being answered. So I really felt that part of the reasons why lymphedema is so scary to many patients is lack of knowledge, and we can help with that. And I understand that lymphedema expertise and knowledge are hard to come by. Many of you have the experience of approaching your physicians, approaching even your therapist, who I know this is going to be on YouTube, so this may upset some physician, but I will say, yes, in general, therapists probably know more about lymphedema than physicians. So that frustrates a lot of patients. So this session is meant exactly for that, for you to ask questions, for me to answer your questions to the best of my ability. Although I need to adhere to the proper therapeutic etiquette, that I should not diagnose you, and I should not be advising you on treatment. I need to keep my response generic and not individualized, because I'm not supposed to diagnose or treat you until I have properly evaluated you, which I haven't. I can't even see any of you. So If in the heat of discussion I forgot to do that, please do remind me. And please do understand that I can't offer formal medical advice on this forum, on this platform. All right, so with that, we can proceed.
Okay, so the way this is going to go is for the questions that you submit, because this will go on YouTube, I will not say your name publicly, so do not worry about that. I will read the question. Dr. Chen will provide the answer or his answer. If we see a group of questions that look, almost identical, then we may skip over that one because it was previously addressed. So we'll go ahead and get started. So first question is, what does he look for in an ICG scan? That's a great question.
Okay, so ICG lymphography is a diagnostic test, just like lymphoscintigraphy. And if you think about various medical conditions, a physician or a clinician, not just physician, any clinician would hear your story and look at you, perform a physical exam, and then have a suspicion, have an impression of what you may have. Note that I used the word what you may have. We need to confirm the diagnosis, especially for a diagnosis as important as lymphedema. Because lymphedema for most patients, it's a condition that they'll need to live with and manage during their lifetime. So we can't be casual about the diagnosis. We need to confirm the diagnosis. Fortunately, it's not common, but I can tell you, I certainly do see patients who were mislabeled or misdiagnosed as having lymphedema, when in reality, they didn't have lymphedema. And even worse, you don't want to miss a diagnosis that's not lymphedema that may require treatment, and the whole time you're being treated for lymphedema. So the first thing before we talk about what ICG lymphography, what do I look for, is why do we do it? So before we had ICG lymphography, we used to do lymphoscintigraphy. And I think as of today, there are still many clinicians who prefer the traditional lymphoscintigraphy, which is fine. I think for the most part, it gets the job done. There are situations that ICG lymphography provides further information. I would say clinicians are in general, more and more are shifting and transitioning over to the newer modality, which is ICG lymphography. As far as what do we look for? Number one, we are looking to confirm the diagnosis. Does the patient really have lymphedema or not? Actually, that's not the most accurate way to describe it. Does the patient have lymphatic injury, insufficiency? So lymphedema is typically referred to as symptomatic lymphatic injury or symptomatic lymphatic insufficiency. A patient may carry asymptomatic lymphatic insufficiency or injury. For example, any patient who had cancer surgery, had lymph node resection, excision, they've already sustained lymphatic injury. So on day one after their surgery, they already had lymphatic injury that frequently would be detectable on ICG lymphography. They may not have swelling yet. So does that patient have lymphedema? Well, most people would say no. Well, that depends on how you define lymphedema. Is it the presence of lymphatic injury or is it symptomatic lymphatic injury? So that's the first thing. Does the patient have lymphatic insufficiency, which implies congenital or injury? Number two, we want to see the patient's lymphatic system. So it's not enough to just say patient has a lymphatic injury / insufficiency. How bad is it? Is it mild? Is it more than mild? Is it intermediate? Is it severe? Is it fulminant? Is it really, really bad that we better bring the patient to the operating room and start fixing it? So severity of this insufficiency and injury, that's important. What we are seeing clinically, so frequently people are equating clinical severity with actual lymphatic injury. So You can think of it like this. A patient who's clinically mild may actually have sustained fairly significant lymphatic injury, but not vice versa. Usually when a patient is clinically advanced, they do have advanced lymphatic injury, but patient may present with clinically mild presentation and actually have advanced injury. So that's number two. We're looking for the patient has lymphedema, but how bad is the lymphatic injury or insufficiency? Number three is to establish baseline. So after we start treating a patient, the patient said, I feel better, or I feel no different, or I feel worse. Your treatment is not working. Regardless of the patient report, that is subjective, although it's very important. There is something called patient-reported outcome. I can tell you that's actually, so short-term, it's not reliable, it's not accurate. 2 days out from your surgery, everybody thought their surgery worked, and we want your surgery to work. So we're all biased. We will bias each other. But long-term patient-reported outcome is quite reliable. But that's a separate discussion. We'll stick to that. Even though reliable, patient-reported outcome is still subjective. We need objective proof that you are indeed better or no difference or worse. And that's ICG lymphography. So without establishing baseline, we can't say that in the future. It's only by establishing an image-based baseline in the future we can repeat the study and compare. Does this patient look better, same, or worse? So again, diagnosis, severity assessment, and establishing baseline for outcome tracking. So these are the three main reasons. There are other reasons, but we won't get into now.
I think that's a great explanation. Second question, what makes a good candidate for LVA?
So there was a time that lymphedema surgeons know how to do one procedure. So we treat everybody who walked through the door with that procedure. Okay, that was a hammer and nail approach. And that was because we didn't know any better. So there was a time that surgeons were divided into lymph node surgeons or LVA surgeons. So the two groups of surgeons debated. Those doing lymph nodes, that was me. Lymph node transfer, if you are not sure what I'm talking about, lymph node transfer. So lymph node surgeons would say lymph node transfer is the best. LVA surgeon also said their technique is the best. But thanks to that experience, that's how we know how each procedure will work in different types of lymphedema patient, because we did those procedures for all of the patient who walked through our doors. So I can tell you, so having done both lymph node transfer and LVA, and having good experience with both of them, I can tell you the question is really not so much whether a patient is a candidate for LVA. The question, so LVA, strictly speaking, would work in great majority of the patient. So if you define candidacy by that definition, then most patients are candidates for LVA. So that's really not, I think, what you really want to ask. What you really want to ask is LVA the best procedure for you, for a given patient? Is LVA the most appropriate patient procedure? So we all know that a good surgery, a good procedure performed in the wrong patient, in the wrong diagnosis, would lead to bad outcome. So a good procedure would only be good in a patient if it's performed for the right reason, for the right indication. So LVA, like lymph node transfer, lymph vessel transfer, and lymph node to vein anastomosis, which many of you probably haven't heard of, LNVA, are all physiologic procedures that treat fluid swelling. It does not treat lymphedema-induced fat deposit or lipodystrophy. As many of you know, that lymphedema in its later stage start to lay down lymphedema-induced fat deposit. Physiologic drainage procedure. So whenever I say physiologic drainage procedures, I'm referring to these 4 procedures: lymph node transfer, lymph vessel transfer, LNVA, and LVA. All 4 are drainage procedures, and they don't treat fatty deposit. To treat fat deposit, you need to remove them, and they're removed by mechanical removal or the debulking procedure. So these are the 2 categories of procedures. So not just LVA, but if you do any of the 4 physiologic drainage procedure for someone who already has, a lot of people like to call it solid predominant disease. That's actually kind of a misnomer, although I sometimes use that term myself just out of laziness. It's actually not. No one is truly solid predominant, but you get the point. That means someone already having a lot of lymphedema-induced fat deposit, then drainage procedure is not the best, because the size of the arm or leg would not significantly improve, even though the lymph drainage would have improved.
Okay. Our next question is, thank you for your time this morning. My question is, would you explain your flying squirrel surgery?
So flying squirrel actually evolved from the classic liposuction, lymphatic liposuction technique. The classic lymphatic liposuction technique does not involve removing skin excess. It was performed with the belief that the skin would completely shrink and contract. And that was the classic teaching. And I think that in many professions, as we were learning from our teachers, we were told the classic dogma. And then once we started practicing doing what we do, accumulating experience, or becoming what others would recognize that we're now experts, we observe things that are different. This is not how I was taught. So some of us continue to follow faithfully the classic teaching, while others will start to question. And that's usually when innovations came. And I do believe that medicine should be advancing through constantly questioning the dogma. Because the state of the art, this is what I always tell my students, state of the art today will become obsolete tomorrow. So 10 years from now, I better not tell you what I'm telling you today. If 10 years from now, if we're doing another lightning round 10 years from now, if I'm still telling you the same thing, then we have failed. That means medicine have not advanced. And so that reminds me to give you a disclaimer. We don't know what we don't know. And in medicine and in science, we always need to have the humility to know that we can be wrong. And we have been wrong many times in the past. One example I usually give is the carbs. In the 80s and 90s, physicians were telling everybody carbohydrates were the best energy source. You should eat a low-fat diet and high-carb diet. Carb is the cleanest energy source. And look at what we're telling you today. So we can be wrong, but still, we need to do our best based on the best of our knowledge to try to help our patients. All right, I think I've deviated from the question.
The
Okay,
question,
but I think I've answered that question.
okay. My CLT diagnosed me stage 1 bilateral secondary 4 years ago. I've had a small flare-up and being sent back for evaluation. Question, I need dental work that will require sedation. CLT told me no IV in the arms. Most doctors will not do foot IV. What are the chances my disease will progress due to IV?
So you should know that there's absolutely no evidence, at least to the best of my knowledge, that IV insertion or blood draw would cause you to have lymphedema or would damage your lymphatic system. There's absolutely no evidence for that. Quite the contrary, there are plenty of, I should say, there's a good number of studies that have shown IV blood draw, IV line, blood pressure cuff in the at-risk area is safe. So, of course, it doesn't hurt to try to be extra safe, to err on the side of safety. So I think when reasonable, you should try to avoid causing injury in your at-risk arm. When reasonable. What do I mean when reasonable? One day I went to the operating room. I found that our anesthesiologist was about to do a central line, a central IV line in my patient. And I asked the anesthesiologist, how come you're not doing central line as invasive? If you know what central line is, it's a large bore IV. It's so much bigger than peripheral IV line and stuck in the patient's neck, in the big blood vessel in the patient's neck. It certainly carries a risk of causing some serious complication. Not to say that it's a dangerous procedure. It certainly is not as safe as a peripheral IV. So that would be unreasonable. I told the anesthesiologist, please do put IV in the arm, even though the patient had bilateral mastectomies and bilateral lymph node dissection. Please do put IV in the arm because you are putting this patient at higher risk of complications. So when reasonable, avoid. When unreasonable, please do go ahead. Knowing that there's absolutely no evidence. So when we educate or talk to our patient, inform our patient, I think the CLT, not just the CLT, the physician, we can do a bit better to tell you what we are basing our recommendation on. So that recommendation is based out of to err on the safe side, but that doesn't mean that they should be trying to do IV in your neck or other odd places.
Okay. That was a great explanation. I think first time that I've ever heard anyone speak to that and using that example. I think that was great. Is there a preferred time frame for surgery following a diagnosis of secondary lymphedema?
So this is a question that if you asked me 10 years ago, I would have given you a different answer. 15 years ago, it's still a different answer. I can tell you in general, in the earlier days, we used to say that surgery is a second-line treatment. So all patients need to be treated and failed lymphedema therapy. Okay, so this actually, I think some surgeons still hold this point of view. But next time, well, try this. I believe all of you are working with lymphedema therapists. We even have lymphedema therapists in the audience. Ask your therapist or ask yourself, what does it mean failing lymphedema therapy? What does that mean? Lymphedema therapy works. Compression works. You don't fail lymphedema therapy. You don't fail compression. So what does that mean failing? Well, if you dig into the literature, you'll be really puzzled. That's never defined, even though that term or that phrase, failing lymphedema therapy, is used in surgical literature left and right as indication for surgery. We never bothered to define to you what we meant. Okay, so that's an interesting observation. But that's at least in my practice and in many surgeons' practice, that's a thing in the past. Now we view surgery as a treatment option, just like lymphedema therapy with compression, lifestyle modification. That's a treatment option. You have high cholesterol. Do you want to manage it with lifestyle modification? You want to manage it with medication? Or, well, it's not here yet. You want to manage with your gene modification. Well, 80% of your high cholesterol is genetics. Actually, diet doesn't do a whole lot. Anyway, different treatment options, different pros and cons. So the short answer is anytime. You can consider, in my opinion, I should say, in my opinion, surgical treatment can be considered at any time, especially when we are starting to offer prevention lymphedema surgery. For those of you, so some surgeons are objecting to the term preventive lymphatic surgery. That meant we offer surgery to patients who are at risk of developing symptomatic lymphatic injury. As I said, if you define lymphedema as presence of lymphatic insufficiency or injury, those patients who have sustained injury, such as lymph node dissection for breast cancer, already has lymphedema, regardless of whether they're symptomatic or not. But anyway, if surgeons consider it acceptable to offer prevention surgery, then we certainly have no excuse to not offer surgery to those who are already symptomatic. So again, to recap, surgery, in my opinion, is an option that any patient with lymphedema, whether they're symptomatic or symptomatic at different stages, can consider. It has different pros and cons compared to lymphedema therapy, which is definitely a mainstay of lymphedema treatment. And it's surgery or not is an involved decision. And any of you who is interested should see and talk to a surgeon.
Yeah, I'm of the opinion that surgery is also deeply personal. There's how close is the surgeon to you? Or do you have support at home, post-op? Does your insurance cover it? Do you gonna have help with the bandage? I mean, there's just so many factors involved with lymphatic surgery. It's deeply involved, and I think that the person that's about to do it should ask a lot of questions and talk to a lot of different people. Next question: is there a generalized list of studies and articles showing the effectiveness of surgery?
So I think every now and then, actually it's not every now and then, frequently, and that's really a frustrating thing. So frequently I hear insurance companies rejecting coverage for lymphatic surgery, saying that there's insufficient amount of studies. And I think these letters are pre-printed. I don't think they're ever revised for the past 20 years. What are they talking about? Just do a PubMed search. There are so many studies now. So there isn't a comprehensive list. Even I don't have a comprehensive list because there are way too many studies. So you can just get on PubMed, Google PubMed, PUBMED. And then once you get on there, search for lymphedema surgery. And yeah, you'll see as many studies as you want, and you can read as many of them. Well, you may only have access to abstracts, but that may be all you want to read. With abstracts, you can get the study design, the study outcome, and their conclusion. So there are a lot of studies.
So just to add to Dr. Chen's answer, the group where you received the invitation to this webinar, if you search for Dr. Chen's name, he has done, I don't know how many posts on published articles with a short explanation. And then there've been discussion threads that you can read through in that Facebook group. I won't mention it here because this is going on YouTube, but if you search his name, you will definitely see a list of articles to begin with, and then you can get on PubMed. Next question. Are you doing surgeries for lipedema, LIP edema? And if so, can you explain what that surgery would involve? That's a great question.
So lipedema is another rapidly advancing field. There's a lot to talk about. And if I start to get into it, I think I'll easily take up this entire session. The short answer, yes, I do surgery for lipedema. Lipedema, as I have presented last year at the FDRS meeting, we are finding that lipedema and lymphedema are very closely correlated. And this is an interesting phenomenon. Patient with lipedema, at least in our experience, even when patients don't realize, even when they were previously undiagnosed, when you perform ICG lymphography in them, you always find a mild, relatively speaking, mild lymphatic dysfunction. So we haven't found, at least in all of the ICG lymphographies we have done in lipedema patients, we found mild lymphatic dysfunction, but mild. It's almost as if lymphedema doesn't get severe when it's coexisting with lipedema. This is very interesting. Getting back to the question, so surgery for lipedema as of today, it's debulking liposuction. And for us, we perform using the same flying squirrel technique. And very commonly, these patients would have a positive flying squirrel sign, so they would benefit from skin reduction and contouring, and the outcome has been phenomenal. Although more importantly, we're also observing what happened to their lymphatic drainage afterward. And so it's an ongoing study. So I won't get into details about that because these results have not been peer reviewed yet, but I can tell you so far they are quite favorable.
And for those of you who want an in-depth answer, more in-depth, when I post up the YouTube video, I can drop some links where Dr. Chen has spoken and actually given PowerPoint presentations on some of these topics, so that if you want to do a deeper dive into that topic, you can watch a full hour on that. For example, the flying squirrel technique. The next question is, please discuss LNVA, how an appropriate lymph node is identified, and how often do you combine LNVA and LVA in treatment?
So LNVA is a new, well, not completely new, but the modification is certainly new technique, the newest technique in lymphatic reconstruction. And as I said, it's applicable to those who still have a significant fluid component, a significant fluid disease component versus solid disease component. So the technique was originally actually allow me to take a few seconds so I can be precise. And Vern, if I don't know whether I'll be able to share my screen. If I can share my screen, I can share the studies. Can I share my screen, Vern? Okay, don't worry about it. It would be interesting for us to look at these original articles together. So the technique was originally described by a Polish
I was on mute. I was answering you, but I was on mute. You are co-host now, so you should be able to.
Okay. All right. So this is a historic study. It's actually quite hard to find them. Okay, so this is a study from 1967. You can see natural history of lymph node to vein anastomosis. Look at the date. Where's the here? And this was a canine model when the technique was originally developed in dogs. And then let me share this. In 1968, then this technique was successfully performed in human by the same Polish surgeon. And as you can see, the original technique was performed in the groin, and they identified a lymph node, and they found this technique to be effective in treating lymphedema. Although since then, the technique didn't gain widespread popularity because the results were not as consistent as surgeons had hoped for. And until the recent modification came about, and this was published by Professor J.P. Hung, and I'll share the screen again. And lymph node to vein anastomosis, and he has a nice picture showing the difference. If you look at this picture on the right hand side, the green chunk of tissue, that's a lymph node. That was the original technique. The original technique would involve cutting off a side of the lymph node and then creating a hole in the vein and attaching that lymph node to the vein. So attaching the lymph node to the side of the vein. And if you look at the picture on the left, this is the modern technique. Essentially, we felt that the original technique didn't work consistently because it disrupted too much of the connections going into and coming out of the lymph node. And in the process, causing too much injury to that lymph node, making that lymph node not working too well. So with modern technique, we aim to minimally disturb the lymph node and then create a small opening on the lymph node and connecting the vein directly to that lymph node. So this is the modern technique. And so LNVA has been shown to be highly effective for fluid disease. Still, it doesn't treat fatty deposit, but it treats fluid disease very well. The choice between LVA versus lymph node to vein, to date, there has been no direct comparison studies done. So I certainly can tell you how I decide LVA versus lymph node to vein anastomosis, but that would be my opinion. There's no evidence-based answer. So in terms of choice, there's still something called catchment effect that we are observing. So let's say if the patient has vulvar swelling, genitalia swelling, lower abdominal swelling, in this situation, performing a connection in the leg, lower leg, versus performing connection in the groin. Usually we see that a connection in the groin would help more directly. Even though both would help, even a connection in the leg would help swelling in genitalia, but it's farther away. It seems to not help as briskly. The response isn't as brisk as compared to a connection in the groin. And if you're going to do a connection in the groin, should you do an LVA or should you do an LNVA? As I said, there's no evidence-based answer, but in my opinion, at least conceptually, lymph node to vein would be more powerful if we're only going to do one connection. If you're only going to do one LVA compared to one lymph node to vein anastomosis, then LNVA should be conceptually more powerful because a single lymph node conceptually drains an entire lymphosome. a lymphosome consists of many lymph vessels. So provided that those lymph vessels are able to get to, drain up to that lymph node, then a single lymph node to vein would bypass and drain many lymph vessels. But these are theoretical speculation. And as I said, to date, no direct comparison done.
That was a great question. Next question, who and where can a patient be assessed for microsurgery bypass in Ontario?
That I do not know. Although I would say check with your local major medical centers. These are the places that are more likely to be offering these advanced procedures.
Next question. What tests do you run for diagnostics during your consultation to determine lymphedema?
So in our workflow, our initial consultation, we actually don't perform testings. So we don't just do one test, we do many tests. We do 3D scanning, we do bioimpedance spectroscopy, we do ICG lymphography, we do quality of life assessment, so on and so forth. So we do a variety of tests. So the initial consultation is to obtain information from the patient to determine, as I said, we need to have a clinical impression of lymphedema in order to proceed with all these testings. You don't want to be shooting in the dark, performing tests on all the patients who walk through the door. So the first consultation, we don't do tests. And for those that we feel that testing would be worthwhile, then we offer those tests. As I said, probably the most significant of all the tests that we do would be ICG lymphography. That would be the central and pivotal test.
Okay. We've got about 13 minutes left to the top of the hour, and I can see in the queue after this next question, we have 14 more questions. We'll try to get to as many.
I will shorten my answers. So we'll try to get through as many as we can.
Oh, I was just letting some of the attendees know that, we may not get to all of them. We'll do our best. The next one is, how do I get my insurance to approve ICG imaging and surgical intervention?
Most commonly, we don't have a lot of difficulty with ICG lymphography. I think the great majority of the patient won't have problem. Surgery is still challenging, but I think your best chance would be to work with your surgeon. Your surgeon should be willing to talk to the insurance company, appeal and submit papers, and talk to do peer-to-peer discussion with the insurance companies.
Next question. If you have lymphedema in your abdomen, will it get worse if you have bariatric surgery? That's a great one.
Bariatric. So it's important to know that what a lymphedema patient can do to help himself or herself. So being heavy is a significant adverse factor to lymphedema. So bariatric surgery is not known to worsen lymphedema, but being heavy can worsen lymphedema. And being heavy can by itself cause lymphedema if the patient is heavy enough. So bariatric surgery, thinking along that pathophysiology, actually may be helpful to a patient who is quite heavy, particularly at a point that we are concerned about the patient's lymphatic system. That patient may be sustaining lymphatic injury by being too heavy. So in that situation, bariatric surgery actually would be helpful.
Next question. Do you see a difference in success rates between primary and secondary lymphedema patients in terms of working with a lymphatic system that was normal before cancer surgery versus a malformed lymphatic system in a primary patient?
Oh, that's a good question. So there's several consideration. First of all, just because the patient had cancer surgery and developed lymphedema, that doesn't default the patient to acquire lymphedema. I definitely have seen a significant number of cases in which the patient truly had primary insufficiency and their cancer surgery triggered a symptom. So that's the first consideration. Not all patients who had cancer surgery develop lymphedema have acquired lymphedema. Comparing acquired lymphedema and or primary and secondary lymphedema, to lump everything together and call it primary lymphedema is also oversimplification. So a patient may be only mildly deficient or maybe severely deficient. If you think about a lymphatic system being intact as 100%, a patient having 90% of their lymphatic function, a patient with primary lymphedema with 90% of their lymphatic function versus someone with only 20% certainly will behave very differently and respond very differently to treatment. But if we're going to generalize, I would say primary lymphedema is a bit more challenging relative to acquired lymphedema. And like lymphedema in general is a bit more challenging to treat than arm lymphedema. Therefore, that makes acquired arm lymphedema being the least challenging entity, and primary leg lymphedema being the most, relatively speaking, challenging entity. So for COT, or I don't know, most likely we don't have surgeons in the audience, but all lymphedema clinicians in general, if the clinician is still just getting into the field, I would advise that initially they build up their experience and build up their confidence in treating the least challenging entity, which would be the acquired arm lymphedema.
Would having liposuction completed prior to surgery decrease effectiveness of future LVNT?
LVNT. There's no LVNT. I'm assuming you're referring to lymph node transfer. The answer is no. Actually, so the conventional dogma when I was in training, I was taught to do reconstruction first, debulking later. Now my approach, and I need to emphasize that this is my approach, there are still surgeons who uphold the traditional dogma. But so our study, which is about to come out, is that liposuction actually does not damage or worsen lymphatic drainage. We've been seeing it consistently again and again on ICG lymphography, and that following lymphatic liposuction, when performed properly, lymph drainage actually show improvement on ICG lymphography. And so assuming you want to do a reconstruction on the patient, in general, the higher the quality of the lymphatic system, the better the patient will respond. So by that logic, it would make sense to do debulking first and reconstruction later.
Next question, is ICG useful even if not pursuing surgery?
Yes, most definitely. As I said, the main three reasons that I said we do ICG lymphography for, none of the three is related to surgery. Number one, confirming that this is lymphedema. Number two, finding out the severity of disease. Number three, establishing baseline. So later on, we can find out whether the patient is better, worse, or the same. None of the three is related to surgery.
Next question, does a patient get a copy of the ICG scan from the Cleveland Clinic for their medical records?
So yes, the patients are supposed to get a copy of the full study. As of today, because we use a new prototype and which is not very user friendly. So our patients certainly can easily get a report of their study, but in terms of getting a CD, I think that's what the patient is referring to. The person asking the question most likely maybe has study done here at Cleveland Clinic. And if you've been trying to get your full study and you're not able to do so, you do have my apologies. You are entitled to get your study, but because of technical reasons, because we're using a prototype machine that really isn't quite commercialized. It's not, doesn't have all the bells and whistles, and the company actually has just been purchased by Olympus, and they're working on this. So eventually you will be able to get your full study. Although Cleveland Clinic, we ourselves are making it more difficult because our cybersecurity also want to ensure that your personal information won't get leaked accidentally. They're actually putting down additional barriers and roadblocks. Anyway, that's really a separate discussion.
Next question. What is recovery from SAPL like? What are the risks and how often do you have to repeat ICG?
Coverage for lymphatic liposuction. I haven't done another review recently, so I can only give you my impression just roughly. I think we're still getting about 70% of the patient cover. And what are the risks? Overall, lymphatic liposuction with our flying squirrel technique is fairly safe. The risk of complication is quite low. And what was the last question?
What are the risks? What are the risks and how often do you have to repeat ICG?
Okay, so it's not how often you have to repeat ICG, since majority of our patients are from out of state or international. We offer a suggested ICG follow-up schedule. We see our patient at 3 months, 6 months, 1 year, and then following the first year, once a year. So these are optional. We do want to see our patient back doing surgery. By the way, if you see a surgeon, the surgeon said, I'll do your surgery and you don't ever need to come back, I would advise that you stay away. Surgical care isn't just surgery. So we want to take care of you. We want to see you after the surgery. And do we need to see you at 3 months, 6 months, 1 year, and then once a year? Since, well, you're from a different country, or if you're from Alaska, we understand. We're not saying that you absolutely have to come back. So you don't have to come back. Most patients voluntarily want to come back at this schedule because it's positively, psychologically, emotionally reassuring. They want to see that improvement, even though they knew already they have so substantially improved. They want to see that objective proof. So yeah, you don't have to return, but
okay. Next question. As a clinician in Phoenix, how do we as clinicians direct patients towards surgeons with the skills to correctly diagnose, parentheses, ICG, and surgically treat or refer to skilled super microsurgeons?
So first, I would recommend that you look up who in your area perform these procedures. As I said, usually major academic centers, major hospital system, you're more likely to find these surgeons. If you're in Arizona, University of Arizona, Phoenix, or Tucson, these would be the areas I would check. And once you have located the surgeons, you can be openly asking them, are you experienced? How many of these have you done? How do you feel about your outcomes? I think, yeah, these questions may sometimes be a bit awkward for the surgeons, but I think we certainly are willing to share this information with you when asked.
I also have a link that I can share, but I'll add it to the YouTube video that's uploaded. So next question, if patient has had 2 episodes of breast cancer and no dissection, how do they decide which arm to use? I think this is referring back to the IV question. Which arm to put the IV in?
As I said, when reasonable, avoid the at-risk arm, but you don't have to go out of your way to avoid it.
Next question. South Korean practitioners are using stem cell transplantation in combination with traditional modalities for treating lymphedema. What are your thoughts on this?
So my thoughts is, as of today, there are certainly many promising modalities being investigated. And in fact, for stem cells, not just in South Korea. It's also in a bunch of other teams, laboratories. As of today, I'm not aware that they're ready for clinical application. So for the time being, so the perspective would be a little bit different when there's a promising, bright, new modality promising that from the investigator standpoint, yes, you want to move forward, try it on as many patient, doing as many human studies as possible. But from individual patient standpoint, there's a somewhat different consideration. Do you want to be in a trial, which may be helpful, which may hurt you? We don't know what we don't know. So I think from individual patient standpoint, the consideration is a little bit different. What we can say is that as of today, it's certainly not a mainstay treatment. There are other treatments, in my opinion, that are much more proven and with much longer track record.
Next question. Are there lymphedema therapy protocols when treating a patient after they have had any of the various lymphatic surgeries?
Can you repeat the question? Are there lymphedema therapy protocol?
When treating a patient after they have had any of the various lymphatic surgeries?
Okay. Yes, there are, but that will take so much time to go over. So I suppose this is a therapist asking question. I'm happy to answer your question. Please do reach out to me. I won't go into it just because it requires explaining each individual surgery, and the protocols are a little bit different depending on the procedure that we're referring to. And since we do a number of these procedures, so it'll take a good amount of time to go through. Please do reach out to me.
Can you explain the positive flying squirrel sign?
The positive flying squirrel sign is when there is skin excess under strong traction, more than 4 centimeters of skin excess under strong traction from the level of deep fascia. So that is the formal definition published. Truthfully, to an experienced clinician, if you look at the patient, look at the degree of skin excess, leaving that amount of skin excess behind will create problem. So yeah, but 4 centimeters under strong traction from the level of deep fascia, that's the positive flying squirrel sign.
Okay, we're down to the last 5 questions.
Okay.
Lipedema surgery. Okay, someone else brought it up. If surgery is the only way to get the fat out of the limb, but the BMI problems that come with lipedema make surgery not advised, what are the viable solutions for someone with lipedema?
So I would strongly recommend, as I mentioned before, all lipedema patients that we've seen have shown at least some lymphatic dysfunction. And as I've just said, that being heavy can hurt lymphatics. So I think patients with lipedema also need to work on preserving their lymphatic function, and that means weight loss. You don't want to add further burden to your lymphatic system by being heavy. And I'd like to, again, this is a field with so many opinions. From what I have seen, lipedema patients can successfully lose weight. So having lipedema does not mean that you cannot lose weight, does not mean that you cannot live a healthy lifestyle. You certainly can. And having lipedema means you have fat deposit that are caused by lipedema that you cannot lose, but it's not systemic. There are parts of you that are affected by lipedema. So patients with lipedema, in my opinion and in my experience, certainly can and have successfully lost weight. And so what you're referring to, the BMI requirement, so treatment safety needs to be upheld. So I understand so frequently, not just lipedema patient and lymphedema patients, we see that in various other clinical scenarios where patients are desperately needing a treatment, but treatment safety needs to be upheld. Patients are held back from getting the treatment they need because it's not safe to move forward with surgery. After all, we are treating you. We're treating the patients. We're not treating their lipedema. We're not treating their lymphedema. We're treating the patients. If we know already a treatment will hurt the patients, we should not do so. And it is our job. Of course, patients don't know. It's not their job to know. It is our job to know. And it is our job to, in that case, advise the patient. In this case, surgery or another treatment will hurt you. So this is a great question. And this is such an important message. And I also do advise any clinician in the audience to uphold surgical safety and treat your patient, not just their condition.
I had a very interesting comment last week by the son of a patient, and he said, I really wish clinicians would not forget that there's a person inside there. There's a person that
Exactly.
we, in other words, the person that you see today wasn't that way 20 years ago or 30 years ago, that there's somebody living inside there, not just a disease.
Exactly. So for a researcher, a patient walking in isn't just another case, where the researcher can collect more data. For a surgeon, this isn't just another case, a procedure that a surgeon can do. And so again, we're doing this to help patients, not just to do the procedure, not just to, yeah.
Okay, last 4 questions. In your opinion, do you think the lymphatic microsurgical healing approach surgery will become the norm during the initial breast cancer surgery when lymph nodes are removed? And if so, how far out are we from that? That's a great question.
So you're referring to the so that's a great question, and you may want to look up the group that had led to popularization of the lympha technique in US out of Columbia, had just published a paper stating that lympha doesn't work. So the practice of lympha is still evolving. So the question is there a role for preventive surgery? In my opinion, yes. I have a different way of doing lymphedema prevention surgery. I don't do it the classic lympha fashion. And in a way, that study declaring lympha not working, I'm not surprised by that. Because we have seen on ICG lymphography that after you many of these patients following performance of lympha underwent radiation, and radiation most likely damaged the delicate LVA that's created in the armpit. I'm not surprised that, again, this is my opinion, I'm not surprised that they found that the classic lympha does not work. If you're interested in our alternative technique of lymphedema prevention, you can look up our study. We performed LVA outside of the field of radiation, basically in the region around the elbow. And also not at the time of mastectomy, but at a later time. Lymphedema doesn't develop overnight. And it's a fast and relatively straightforward procedure. Outpatient procedure takes about less than an hour, can be performed under local anesthesia or under general, depending on patient preference. And if you're interested, please look up our study.
Okay, next question. Are there any lymphedema therapy protocols when treating a patient after they have had, oh, that one was already asked. Next question. Are there any supplements or medications helpful for the lymphatics?
Not that we know of. Although the growth factor, VEGF-C, VEGF-C, which is a growth factor for lymph vessels, have been shown not to benefit extremity lymphedema, but has been shown to, so we're slightly off topic, but I think you would find this interesting. So we have found that Alzheimer's disease, Parkinson's disease, Huntington's disease are likely to be lymphedema of the brain or lymphatic dysfunction of the brain, which means that by improving lymphatic function of the brain, we can potentially treat these conditions. And in animal models, people have found improvement of their, improvement of these neurodegenerative conditions in animals by administering VEGF-C. So that would be a medication, that would be a growth factor that can be administered. I'm not aware that it has been done for extremity lymphedema, but it has been done in animals for these neurodegenerative conditions. And it's exciting. We might be able to treat dementia.
Yay. Last question, final question. How do I schedule ICG testing as a non-surgical candidate? I was already turned down for it because the BMI precludes me from surgery. I still want to map my disease even if I never had surgery.
So I think inquire your local major medical centers. I know for the time being, if you have inquired about Cleveland Clinic, and if you're turned down, again, I apologize. We currently are having such number of patients who are waiting, who are surgical candidates and who are waiting for their studies and waiting for their surgery. So for the time being, just so we can help as many patients as we can, we are temporarily not offering ICG studies to patients who are not candidates because it won't change their management. I think it's still helpful for you to gain insight into your condition, although temporarily we're not capable of doing so for you. But ICG lymphography, the availability of ICG lymphography is certainly more available compared to surgical expertise. So certainly inquire centers that are close to you.
Dr. Chen, I want to thank you so much for teaming up with me again.
No, thank you for the opportunity.
As I said in the beginning of the video, This was on your personal time, my personal time. We're just two friends who believe in the power of patient education. That, you know, as I said before, the decision to have surgery for me, in my opinion, is deeply personal. But I know that Dr. Chen agrees with me that if and when you decide to move forward, you should have the most accurate and relevant information available to you at that time, because that's how we make informed decisions, is by asking questions directly from the clinical expert source. Again, these are his opinions, but it's a great place to start, right? We have to start somewhere. Anytime you're researching a topic, you have to start somewhere. And I want to thank everybody for joining us this morning and for all of your support. They were great questions asked. This video is going up on YouTube on my personal channel, which is called Veronica Cineris, under the Magenta Table Talk. Thank you so much and have a wonderful day.
Thank you, everyone.
Take care.